Hello, can you
Yes.
hear me?
Yes, can hear.
Okay. This is a 58 years old patient. Been having back pain for the past 10 years, which is progressively worsening. Initially back pain, and then later on have this bilateral radiculopathy. That time the pain towards the right leg is more on the left side and around the dermatome L4 and L5, which are at the lateral side of the leg and at the calf region. So during that time, I really, and also having this back pain, the arthritic, what you call that, joint pain at the facet. So that time I really offered him 6 months, 8 months ago, left side L4, L5 DRG block, and then this bilateral facet L3, L4, L4, L5, and L5S1, RFA lah. So with that, he said the back pain towards the leg reduced, but still having, even though the pain, the radiculopathy reduced, he's still having some back pain, residual back pain. But the pain compared to previously is less, but still persists. With that, I told him may need patient, we can try another procedure, which is this PLDD. So he is keen for this procedure. Today, we intended to do this L4, L3, L4, L5, this level, to address the back pain. And there's on the MRI, there's look like a small tag around the L5S1. We discussed with Dato just now. Dato will try to demonstrate the L5S1 to show that the leak, the leak in the contrast and then we will do some procedure at that region if the procedure is successful. If not successful, we will concentrate on L4, L5 region only today.
Okay, thank you.
Okay. Here we go. Ya, sama dengan tadi dah. Thanks. Thank you. Same. Same. So as usual kan kita akan scrub dari bahu sampai ke paha lah. And then dari tepi ke tepi. As usual. Macam buat bedah lah. And then kena gaung. No choice. Because kan, kalau ada infection kan, memang kalau kita tengok senarai kita, ada tak kita buat dengan sedaya upaya untuk mencegah infection kan. Kalau kita tengok senarai checklist memang dia gagal lah kalau tak ada scrubbing yang baik ya. Yes. Exactly. Sebab problem is kita masuk ke dalam sekali. Masuk ke sampai ke disc. So I think that is the main thing, And some more, the disc is avascular. So takut infection lah. So we are worried about sometimes obligate anaerobes lah. Dia orang tak perlu oksigen banyak. Tak perlu, habis.
In my practice with
Yes.
surgeon in
Yes.
because we did RF, so when we do
Okay.
RFA,
Okay.
after take out, we inject steroid inside. That's why I asked you.
Okay. We normally try not to. We try not to.
There's a risk.
That's a major risk. That's a major risk. Because you have steroids in an avascular environment. Exactly. And then you've got recent thermal injury with necrosis. So we'll try to minimize it as much as possible. Minimize it. Then whatever contrast medium that I injected earlier on, kita ada antibiotic, ada gentamicin juga. But still, I will take out everything. I'll aspirate as much as possible. Yeah, before I go in. Safer.
very obese patient,
Difficult.
very thin patient,
It'll be a
you can
challenge.
share with us.
Even very thin
Later,
patients can be a problem.
Yeah, that's why later
When you go in, sometimes in very thin patients, sometimes there is this absence of give,
Yeah, correct.
even though you went through the
patient,
illness.
yeah.
So when you look at the lateral side, like,
You're too deep.
oh my God, I'm so deep.
Oh,
Hmm.
yeah, quite scary, isn't it?
Scary, scary, scary. But guys, sedation is probably not the way to go, lah. It has to be a
I always
dialogue.
thought that a bit of sedation would be good to
The
reduce
sedation
the
is more for us
Yeah.
because we don't hear the patient screaming.
Yeah, yeah.
But in real life, I think a lot of talking is important.
From them.
Yeah, a lot of feedback.
That's another like my part. We practice patient is GA.
Okay, okay.
But it's as a surgeon,
That's even worse.
Yeah,
happy to do lah.
Yeah.
Because patient not moving.
exactly.
Very risky if anything.
Better to have them. Better to have them.
Oh, saya tak tahu, saya tengok. Just jangan block ni lah. Sama boleh.
Kalau ada terblok, aku tak ingat. Tak perasan.
Agree.
Sebab yang ni kau shoot tu. Yang ni sini. Oh, kalau yang salah yang tak baik salah yang sana lah.
So nanti kita cuba L5S1. Hopefully, yeah, hopefully. Yeah, so we may have to abort if we can't reach it. We'll try and do it. We'll try. The problem is that L5S1, that I believe on the MRI scan, I believe I saw an annular tear.
That means
It's uncontained, yeah. So normally for uncontained discs, whatever reduction in volume that you can achieve and whatever changes in pressure that you can achieve is immediately equalized by the outside pressure. So you don't get an appreciable reduction in. That's the problem with with the annular tear. But we'll still try. We'll still try. We'll still try. Yeah, we'll still try. So if you notice, Mr. Ong starts from the center, and then he goes in ever widening circles, and he never comes back to the place again. Besok rapid fire, besok.
Which session?
Besok rapid fire.
You have recipe.
I have to present. Pasti,
tomorrow, yeah.
pasti kena teruk.
That one 5 minutes, right? The
2 minutes presentation.
It's one rapid fire.
Yeah, 2 minutes presentation, and then I think 4 minute questions. Habis lah. Besok. Pasti kena bombat. Stres tau. Stres.
I just masuk the start program.
Yes.
Sudah kan the presentation.
Oh, ya. Encik Yusri, sejuk sikit lah, minta maaf. Sejuk sikit. agak sejuk lah, menggigil. Okay, all right then. So again, we try to present a small field of operations lah, as small as possible. Contamination. And then if the other side is not going to be done, then put your drape on the midline. That will make it even smaller. Even smaller. Yes, better. And then
The symptom is on the
actually, to be fair for him, it's bilateral.
Oh, okay.
It's bilateral. Both sides are equally bad. We have people who do bilateral as well, but it's difficult to predict how the reduction will be. It's difficult.
It's not like just straight.
Yeah,
It might be
it's quite random. You know, it's quite random.
But I think your style is more towards you approach through the pathology side.
Oh yes.
Yeah.
Oh, yes.
Because sometimes people like to come,
Oh,
some
I was like-
surgeons like to come.
Yeah,
from
contralateral.
opposite, yeah,
Contralateral. Okay. Super. Okay, let's have a look. All right then. Okay. Encik Yusri, kita bermula sekarang ya, Encik Yusri. Kita bermula sekarang. Okay. Won't be easy, but we'll try. We'll try. Okay. Okay, siam masuk and then LA. So LA only on the skin. Inside no LA. No LA. Okay, here we go. Thank you.
Prof, are we going to do 5-1 or 4-5 first?
Yeah, we'll be doing 4-5 first, which is the main pathology. And then once we're done with that, we would attempt L5S1.
All right.
And we hope we hope to succeed screening. Okay, screening. Okay, screening. All right then. Rankston, I will try to square the vertebra. Okay, kita condong sikit. Okay, thank you. Screening. I think better.
Better.
Much better? Much better. Screening. Okay, screening. Even better, my God. Okay, okay. Okay, she's very good. She's very good. Okay. She's very good. She's very good. Screening. Okay, I'm right there. So, okay, I know the inclination now based upon the C-arm. So what I'll do is I'll carry on. I'm actually feeling for the quad lumborum, erector spinae, and I got it here. I got it right here, here. So I'm going through here itself. Encik Yusri, kita akan suntik sekarang ya. Saya suntik dekat sini lah, dekat tempat yang saya picit sini. Supaya Encik Yusri tidak terkejut apabila jarum masuk ya. Okay, screening. Okay, all right then. I think communication important.
Very important.
Important. Encik Yusri kat sini ya. Kat sini lah. So a bit of gating mechanism here going on. A delta fibers being stimulated. Hopefully it will reduce the C dorsal efference. Hopefully. Gating mechanism, yeah? Gating mechanism. Here we go. All right then. Encik Yusri, kita suntik ya. Minta maaf. Kita suntik sekarang. Okay, best. Very good. Okay, good. Sekali lagi Encik Yusri disiksa oleh kami. Okey. Baik. Okay. Screening. Okay lah, more or less correct. So once again, okay, saya urut sikit ya. Saya urut sikit. Once again, we will check the filament assembly. So as usual, as you know, it's already preset to fit this. So it's already preset. So if I were to remove the cannula trocar, and if I were to unfurl the filament assembly here, then it should protrude beyond the edge, about 3 mm. So about 3 mm. So if I were to do this, any closer, it may actually give you thermal feedback along the sheath. You know. Aku dah tua dah, aku ni. Aku dah tua dah. Okay, here we go. So this goes in, and then that's it. So it protrudes.
Yes.
Yeah. This is pretty good. This is good. Yeah, you can see better on the white background. Yeah, 3 to 5 mm usually, and then we will leave these untouched. Sometimes, if the assistant is a new scrub nurse, they may inadvertently touch this and click that, and every click increases it by 2 millimeters. Yeah. Yes. So now that we're done, we test the filament and see, is it a dud or not? Yeah. But usually it won't be a dud. Usually it'll be working. But just in case. Just in case. Just in case. Kita nak peluru pandu yang boleh meletup. Sorry lah, I emotional sikit. Emotional sikit. Tak tahan lagi. Okay, here we go. Okay, can someone press down on the pedal for us?
Pressure is with me.
Go ahead.
So I start test.
Yep. Okay, it's definitely burning. Thank you. Thank you. Thanks. Okay, off laser. Off laser, and then cannula. Okay, here we go. So this is a straight cannula, okay, for L4, L5. Later on, for L5, S1, we may have to bend it. Okay, yeah, we'll use straight. Okay, here we go. Right. Okay, so guys, same thing. I'm starting from the edge of the muscle, and then I will, of course, use this to direct me a little bit. Yeah. Encik Yusri, kita akan suntik sekarang ya. Okay, Encik Yusri. Okay. Screening. Alright, screening. Okay, kita pergi oblique my side dengan kecondongan ini lah. So now we're going oblique to my side, to our side. Usually between 30 to 45 degrees. As long as you can see the Scotty dog.
Right.
Yeah. Different patients will have different angular requirements. Okay, I think I can see the Scotty dog.
Yeah, beautiful.
Yeah, and I think the disc is bigger than earlier on.
Yeah.
So what I'll do is I'll go caudally now. Shooting. And then I'll go medially as well. Screening. Screening. Okay, and then I'll proceed now. Screening. I may have overshot on my caudal. I will correct it. So I'll try not to go near the tip of the ear because that's where the root is. Screening. Screening. Okay, Encik Yusri, dalam sebentar Encik Yusri akan terasa sakit di sebelah kanan Encik Yusri. Di punggung kanan, di paha kanan. Kiri, sorry. Di kiri, aduh aku ini. Di kiri dan di betis kiri. Ya. Encik Yusri, terbuktinya doktor penyamar. Okay, screening. Last night I saw Encik Yusri without lencana and without seragam. Screening. Baik. Screening. Okay, Encik Yusri. Kita akan suntik masuk ya sekarang. Jangan takut, Encik Yusri. I got the annulus. There's a feel for it. Screening. Okay. Safe. And then AP. So we are well in the Cambin triangle. Yeah. Then, okay. Screening. Okay, we're in. Guys, can I just ask you all to just feel the push, yeah? 2 hands, push it slightly. Okay, screening. Okay, a bit more. Okay, screening. All right, lateral. Super. So there has been no radiculopathy. Mr. Ong is keeping a close check on that with Mr. Yusri. We'll see what happens on the lateral side. Mr. Yusri is slim, so there's every chance that we've already achieved where we are. Slim. Slim. Mungkin kita kena, ya. Okay, mungkin kena adjust sikit. Mungkin condong sikit. Serong sikit mungkin, ya. Kita kena adjust sikit. Yeah, yeah. Right angle, right angle. Okay, table higher. Okay, I think siam kena ke dalam sikit. Yeah. Baik, okay. Okay, still not square. Double line and plate. Is it better or worse? Oh, the other way. The other way. Now, try to feel and see. Boleh masuk lagi? Go ahead. Yeah, boleh masuk lagi. 2 hands, ya. Okay. Okay, hold on, ya. Okay, carry on. Go ahead. Masuk lagi. Okay, screening. Sikit lagi. Boleh masuk lagi. Encik Yusri, you're okay, ya? Baik. Kita dah mencapai dekat tengah tulang rawan tu. Dalam sekali. Shooting. I'm still getting a double line end plate. Can we get the? I think this way. I think this way. No? I think this way. Yeah. Some swing. Swing. You know why? Because I'm still getting a double end plate. Patient is like this. So I need a right angle. So this end, yeah. Okay. Okay. So much better? Much better. Dalam sikit. Dalam sikit lagi. Okay. Screening. Okay, I'll put a bit more, yeah. But you got the feel, right? You got the feel, yeah? A bit of resistance, yeah? Screening. Right, okay, I'm a bit near the end plate, so I should stop where I'm ahead, okay? Screening. Okay, I shouldn't be too near the end plate. All right then. AP, boleh tengok AP.
Okay, tak apa, tak buat.
Good lah, very good. Hopefully FIS1, hopefully FIS1, hopefully. Okay. So I think we are still quite safe lah. We're still quite safe, yeah. But I did not go much more because of the end plate. Yeah, the end plate is too near, yeah. Okay, so let's go back to lateral, and then we can do a discogram. Discogram, okay, contrast. Okay. I'll let them do a discogram. I will hold the cannula. Thank you. Okay, guys, discogram. I'm holding the cannula. I'm holding the cannula with 2 hands. Okay, all right. Screening. See, I'm down. 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 Down. Okay, let's have a look. Looks good. Okay, all yours. All yours. Encik Yusri akan terasa sakit belakang sikit. There will be resistance. There will be resistance. About 1 ml will be good. Okay, let's have a look. Screening. Yes, you have a discograph for sure, and there's no leak. Okay, it's time to put in the filament. Okay. Filament. So I'm taking care not to touch the clip for fear that I would, and make it even deeper. So over here, I try to screw the filament instead of rotating the cannula. Screening. And now I will unfurl it by withdrawing it a little bit. Okay. And then I'll do a test dose right now with the pedal. A test dose, yeah? A test dose. Okay. Okay, patient is primed to inform us if there's pain. Here we go. All right, here we go. Is it firing? Is it firing? Laser ready? Go. Encik Yusri. I think it's continuous. There's no pulse. Let's change settings again. It's continuous. So that's the final evolution of the laser generator. Handheld. I think I'm wrong. I shouldn't say final. It'll probably be smaller. Here we go. Firing. Encik Yusri, small okay. Baik. 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 Good. Let's carry on. Guys, maybe if you can have a feel of the pedal. So normally I would use 7 cycles, 7 beeps or 8 beeps, then I get off. Can I see? Go ahead. No nothing at all. Carry on with the 8 one. Okay, then we rest for about 5 seconds. Let it cool down a little bit. And then let's go. Let's try it out. There's a certain feel to it. Let's try and see how it is like. Please go ahead. Go. 8 beeps. Yes, 8 beeps. Encik Yusri, small okay. Baik, baik, baik. Okay. Okay. We have a choice. You can have it jump about 12 joules per step. I admitted to him 8 joules. 6 to 8 joules. So if you do 8 times, it hits about 40. I went beyond 8. So far, no bubbling, guys. So far, none. Yeah. So I'm going to pull out a little bit, and then I want to check. Okay, screening. Okay. Now you notice that on the lateral side, the penetration is deeper than the AP, which is not so midline. So in this case, I didn't achieve parity between lateral and AP. I didn't achieve parity, which means that the tip of my needle is a little bit more lateral than I wanted it to be. So I think it has implications for us not to trust the lateral view alone. In this case, I think the AP view is probably more important than the lateral view. So I guess for safety reason, always check, always go by the view that shows you the lesser penetration. Safer. Logically. You realize I went above 8 beeps. Okay, I want to just turn this because sometimes you have to turn it a bit. Okay. Now, Encik Yusri has done RFA before. Yeah, he's been through some some procedures, yeah. And in terms of age, you will expect some desiccation, but then again, you do have bubbling. See, there's bubbling now. I shifted the thing, and so sometimes randomly when you shift, you will disrupt the internal environment a bit. So maybe the filament sweeps, maybe some gas bubble gets displaced. Perhaps there's a place where there's a little bit more hydration, and then you start getting bubbling again. Some of us actually aspirate out the contrast medium before we start laser. Yes, some of us do that. Some of us do that. Then if you do that, then you need less joules, because a lot of the joules is to burn through the initial contrast medium. Normally, I do not exceed 2 ml of contrast medium, normally. Okay, inject U3, semua baik. Good. We are at 300 plus. Yeah, okay. And also me and my eyes also. Eyes also. It's time. There we go. Pushing it out. Pressure is pushing it out. That's what we want to see. Eh? We want this pressure to come out. So it is unsurprising that one can go up to 1,000, 1,002, with this, because that's what it needs, you see. But then again, it depends upon the size of the patient as well. So frequently, I find myself doing less than that. And Ethan here is my faithful co-conspirator in the OT. So we frequently go less than that. But it is easy to reach 1,002, 1,005. Again, consensus. I mean, there has to be some major consensus on this. There isn't any yet, but you can see that most people abide by those ranges. Yes, by those ranges. Okay, it's bubbling up. So I'm going to pull out just a wee bit. Screening. Okay. After a while, I have to look at the AP also. Okay, inject U3, masih okay ya? Baik. Baik. So more bubbling. Sometimes it runs off. Ada abu sikit. Sometimes. Empty syringe. Getting impatient. Sorry, guys. Inject U3, mungkin sakit sikit ya. Any change in volume, he might get some pain. So I'm telling him first lah. He might get some pain. Okay, let's do it. Dryer now. Yep. 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 Yes, you're right. You're right. You're right. It's not bubbling like anything. I think age also, more advanced. 40-ish, 50-ish, yeah. 50-ish, 40-ish. Yeah. Inject U3, okay, yeah? Okay. Good. Bye. Bye.
Prof, I have one question.
Yeah, shoot.
Your pulses, how long do you stop before you pulse again?
Yes.
The
so
interval.
again, consensus and human impatience. Usually 6 to 8 pulses and then a stop for 5 seconds. I'm unfortunately bending rules here. I think the overall thing is to avoid overheating and to avoid over-treatment of a particular focus.
Because I usually, I think I pulse a bit faster. Lah.
Yes.
But the thing is, what I notice is that's why I need sedation because I think the temperature builds up very fast.
It does. It does.
So probably that's why you don't need sedation.
No, I don't.
Yeah.
I'm willing to spend, like say another 10 minutes more in order to talk to the patient and then to get feedback from him, I think that is so much better.
The other thing is I notice sometimes they actually complain of dysesthesia,
Oh yes, they do. You're so right. They do. I think probably sometimes also when during our entry into the annulus, sometimes we may have actually created tension forces along the tissue, the connecting tissue, the deep fascia inside that connects the lumbosacral plexus. And I think that goes a long way in giving you some neuropraxia as well. And then add that to our annuloplasty. I think thermal changes are also responsible as well. Screening. Okay, I think it's almost time to do an AP. Let's do an AP and see. I'm holding off any more pulse until I see an AP. I'm almost at, I think, 800-ish. Ethan, how much are we? Around 900, yeah? Okay, sure. Okay, all right. Guys, we owe her big time. Okay, all right. Okay, screening. Okay, all right then, still safe. Encik Yusri, okay, yeah?
Okay.
Rangson, this is my V4130 working. Amazingly, there's still some bubbling. Yeah, let's do a bit. Okay, here we go. We'll stop at 1,000 because Mr. Yusri is not exactly big size. He's ramping and fit, slim. I don't think he's even 55 kilos. No, 60 kilos. Less than 60, I think. Yeah. So I think we will stop at 1,000 plus. Yeah, good.
When you look at the AP, what are you looking at? The tip of the needle?
For me, I am particularly worried about the pedicle relationship.
The medial pedicle.
Yeah, the medial pedicle. I would like to err on the side of the medial pedicle. Okay, we breached 1,000. Okay, KLSE has reached. Let's withdraw off laser. Laser. Okay, filament out. You can smell the burn smell. Yeah, you can smell the burn smell. Empty syringe to suck out whatever residue is inside. Let's not leave anything inside, including the smoke. Yeah, a lot. So with the 20 cc syringe, you can really suck out a lot. Okay. All right then, and then we have the shin clot. Okay, I think I have to tell Encik Yusri already. You're going to feel unpleasant for a while. Yeah, for AP, yeah. You can really smell the burnt smell, yeah? You both smell it, yeah? Okay, Encik Yusri, kita bermula sekarang. Minta maaf Encik Yusri. Ini seksa lagi, pusingan kedua ni. Seksa demi seksa. Dah start dah? Dah start dah? Yeah. Okay, so I'm taking just half, because I'm looking at L5S1 now. L5S1. Okay. And now, L5S1. Okay. Boleh tak kita condong sikit lagi? Okay. Okay, trocar. Trocar. Gauze. Okay, gauze. Muscle. Muscle. Okay, all right then. Okay. Yo, hopefully, screening. But I promise, Encik Yusri, that I will try. Let's try and see. I'm not getting squaring, huh? Okay, kita condong lagi sikit. Okay. Better, no? Much better. Encik Yusri minta maaf ya. Okay, so now I have anatomy fighting against us now. The angle. You notice that I'm not bending it? I'm not bending it.
Oh yeah, you have.
Yeah, I normally bend it. Screening. I would prefer to bend a thicker cannula. Screening. Okay. 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 Oblique my side. Okay, all right. Some more. Some more. Okay. Some more sikit lagi. Okay, good. Screening. Okay, Scotty dog. Oh dear. Small window over there. We are actually on target, but then it's not well depicted. I would like us to, square it further. Yeah. How bad is the lordosis? That one, right?
Yeah.
Much better. Much better. Much better. Are the cameras getting it?
Yes, we can see the over-the-top position quite
so
clearly.
it's much better now. I think we'll have to inform Encik Yusri again, this time for real to the toes, to the left toes. Menjala ke kaki, ke jari. Tumit dulu, tumit, tapak, jari. Baik, let's do it. Come guys, let's do it. Okay, screening. I wish I had bent it, bloody hell. Screening. Yeah, there's a small window there. Screening. Screening. A bit ossified. I'm trying my best, but it's a bit ossified. It's a bit ossified, guys. It's so ossified that, see this? See this?
See the whole body moving.
Yeah, a bit ossified. We are in trouble here because it's ossified. It's ossified. Let me try again, yeah? Let me try again. So we have an ossified annulus. Let me try again. Encik Yusri, okay, yeah? Okay, let me try again, yeah? Let me try again. Okay, siam tinggi sikit. Sikit lagi. Sikit lagi. Baik, thank you. Okay. Let's try again. Screening. Oh dear, screening. Okay, let's try again, guys. Encik Yusri, okay? So far, okay, yeah? I keep remembering that Maguire Atlas and the roots that emerge from it. And it becomes very inhibitory. Screening. Okay. I'm in the triangle. Screening. Okay, but I'm not going, I'm going too lateral. So again, that's why, like what Mr. Rangson mentioned earlier, yeah? Pre-bending of the cannula is a very good choice. Screening. And I would like to exhort the industry to bring in a larger caliber one. Screening. I'm still going lateral, Let's do an AP and see. Let's do an AP and see how lateral we are. Because I'm in the annulus. Let's do an AP and see. How lateral are we? We're not too bad. Seriously? Okay, seriously? We're not too bad. Okay, let's go a little bit because I know how much of anterior tolerance he has based upon just now. Screening. Not bad. Not bad. Not bad. Let's do a lateral and see. Let's do a lateral and see. Let's do a lateral and see. I think the squaring helps a lot. It gives you a good window to go in. So in Penang, Ethan and I have been known to encounter very ossified discs because some surgeon selected it wrongly. Don't know which surgeon also. Here we go. All right, then screening. Ong, what do you think? Go down a bit more. Okay. I can't see well from here. Okay. Ong, what do you think? Okay, can we go in a little bit? No, is it anterior? It's very anterior, you know? Yeah, I think it's time to withdraw a little bit. Okay. Screening. Screen. Okay, let's do a discogram. Yeah. So guys, we are anterior, you know. As expected, because of the direction of my trocar, which was going laterally, as expected, my egress on the AP is far less than my egress on the lateral. So on the lateral view, so which means that I'm very much lateral. Encik Yusri akan sakit, ya. Screening. Okay, maybe a bit more. I'm holding it, don't worry, I'm holding it. Okay, maybe annulus, annulus, that's why. Screening. Okay, annulus. I'm going to withdraw a little bit. Okay. Screening. Yeah, it's there. It's there. It's there. Screening. Okay, confirm. It's not leaking from the anterior. Screening. Okay. Let's do an AP. We'll rely on the AP, Rely on the AP. So folks, I'm relying more on the AP now because the AP has far less penetration than the lateral view. So it is the AP that I have to watch out for. The lateral view will only give me false comfort. Screening. And I don't have much room to play, but we will try it. Okay, so we'll test the filament again to see if it's working. If it is not, then, or if you think that the crackling is not up to par, then do change to a new filament. Right, here we go. Go ahead.
Dah tekan. Ready,
Not so good, you know. Not so good. Not so good. So this happens sometimes, really. So let us not take the filament for granted. I mean, it has probably undergone some, yeah. Some surgeons like to snip off and then continue with the journey. I would not like to do that. I would use the new filament. So we'll use the new filament. The new filament. And you see, okay, yeah? Okay. So some of us actually snip off the end and then continue with the journey. You have to adjust it accordingly. You can adjust it again. You can adjust it again. I would use a new filament. I would use a new filament. That is a very, very, very poor discogram. But it is a discogram. But it's very poor. It's very poor.
Not go lateral, right?
Yeah, it is lateral, very lateral. So I don't have much space to play with. Anyway, it's quite desiccated, you know. It's quite desiccated. Yeah, it's a good demo. It's a good demo to see. But I think the squaring helped a lot. Helped a lot. Yeah, very nice squaring from her. Yeah, we owe her. We owe her. Very nice squaring. Okay, so it's preset. It's preset. So, Ethan, there is actually more reason to ask the producers to give us the next thicker level. There's one which is slightly thicker than this. Yeah. And if they have a pre-bend one, we can take the pre-bend one as well. This is burning well, yeah? Good, very good. Okay, so always test, always test the filament. Sometimes if we do not test and then the filament goes, it doesn't really do anything. Then that's probably because it's not functioning well. Okay, screening. I'll pull out a bit already. Screening. Okay, good, excellent. It's even out now. Okay, this is the time where we're gonna ask Encik Yusri any left pain and that. Encik Yusri, kita nak bermula ya. Sakit tak Encik Yusri? Becoming an annuloplasty ini. So I think the main thing here is to stop if there is discomfort. Yeah, I think that's the extremely important thing. Any delay in telling us wouldn't be good. Yeah, it is still coming out. Yeah,
There's some bump.
not bad. Because there's hardly any contrast material there, so it's good. We have a bit of nucleoplasty going on here. Good. I've gone beyond 10. Yeah, I've gone beyond 10 already. Okay, still good, eh? Very good. Yeah, there's some bubbling. Good. There's very little contrast medium inside. Very little. Oh, yeah. Yeah, you're right. Okay. In your place, are the patients okay for laser? Will they agree?
Most of the time we surface, but we didn't do PLDD.
Okay.
We haven't tried.
Haven't tried. No? I think can offer them the gap between conservative and surgery. There's a gap there. Then maybe once you get that relief, then maybe with rehab, with proper ADL modification, they can escape surgery. Hopefully, we try to get that segment of the people. I think easily, of all those people who are destined for some form of intervention, maybe we can get 40 to 60% off.
Yes.
This is from the poking around just now, pushing at the bone, at the ossified part. One part is ossified. Yeah. Still good, yeah? A bit? No. Kaki penting. Sikit, ya? Still good. Okay, carry on. But it's desiccated. It's desiccated. Yeah. It is. Amazingly, amazingly. So we'll try and maximize it. See whatever reduction in volume we can get from him.
Tapak kaki rasa panas.
It's time. It's time. It's time. It's time. It's time. The enemy of good is perfect. Let us not push our luck. How much? I think it's time to stop. Yeah, time to stop. But he's already feeling it already. Good. Excellent. Okay, laser off. Laser off. Let's remove the gases with the empty syringe. I don't think there's much fluid, but then the gases. The gases. Empty syringe. Okay, here we go. Hey guys, you're right. There's some fluid there. You're right. Okay. All right then. Okay. Encik Yusri has to be warned that there will be unpleasantness again. Thank you, bang. Okay, unpleasantness. Bermula sekarang. Screening. Yeah. Okay. Good. Okay. One wound. Good. One wound. Good. Okay. Good.
Anybody has any questions before we close? Okay. Okay, Datuk O. Hello.
Thank you, Dr. Mason, for holding us through the session. They will wrap up on the OTs and then they will come down shortly for another discussion after the live surgery. So in the meantime, while they wrap up, we do have packed lunch prepared at the site. So we will arrange for everyone to get the packed lunch and then we will have the lunch while waiting for them to come down, right?